Good afternoon, everyone. My name is Janice Whitaker, and I'm the administrator for the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence. It's my pleasure to welcome you to the CGNE seminar today. And I want to thank Jenny Rank, our co-host. She helps to do a lot of the organization and the behind-the-scenes work that makes this seminar series successful. So thank you to Jenny. Today's program is sponsored not only by our center, but also the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Stress, Emotion, and Cognitive Aging, the Role of Inflammation and Importance of Prevention, will be presented by Dr. Jennifer Graham-Engeland, Professor of Biobehavioral Health and Associate Director of our friends at the Center for Healthy Aging at Penn State. Before the presentation, we do have some announcements and disclosures. Penn State Ross and Carol Neese College of Nursing is approved as a provider of continuing nursing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1 contact hour. Partial contact hours are not awarded. To earn contact hours, Zoom in and out times will be recorded for attendance, and the post-event evaluation must be completed within 1 week of the seminar. Certificates will be emailed to RN participants meeting all requirements within 1 month following the seminar. Just to make you aware, this seminar is being recorded. If you ever want to watch any of our seminars, Jenny does a great job editing, uploading them to the YouTube channel. So please check that out. If you have any questions or comments for our speaker, you want to participate in our discussion, please, you can either enter that into the chat or you can raise your hand and Jenny will unmute you so you can speak aloud. The post-event evaluation link will pop up in your browser when we conclude the webinar, and it will also be emailed to you within 24 hours. We do encourage everyone to complete the evaluation, but it is required for RNs that are seeking contact hours. And if you have any questions, please feel free to reach out to us at cgne@psu.edu. Next, I'd like to introduce Solomon Tagbor, who is one of our fabulous CGNE affiliate PhD students. He's in his first year of his program, studying chronic disease management with a focus on diabetes. And Solomon, we want to thank you also, not only for introducing our speaker today, but being such a help and support at our recent CGNE spring brunch event. You helped us with the check-in table and so many other things. So thank you so much.
Thank you, Janice. Today's speaker, Dr. Graham-Engeland, is a professor of biobehavioral health and the Associate Director of the Center for Healthy Aging at Penn State. She is also the Director of the Mechanisms of Emotion, Stress, and Health Lab. She served as the Director of the Biobehavioral Health Graduate Program for about 7 years. Dr. Graham-Engeland is a principal investigator on multiple NIH-funded projects and a co-investigator on other funded research projects. Her research focuses on connections between stress, mood, and multiple different physical health indicators, including cardiovascular disease, chronic pain, and cognitive aging outcomes, using novel methodological approaches to determine mechanisms as well as to elucidate novel clinical translational intervention strategies. She investigates the impact of cognitive and emotional responses to stress. Example, rumination, meaning making, anger, that are potential targets for non-pharmacological intervention, drawing on perspectives from social psychology, psychoneuroimmunology. Specific questions include the ways in which emotion and inflammation exacerbate chronic pain and cognitive decline, adaptive consequences of negative emotional expression, and the relevance of situations and individual differences, example, age, hostility, loneliness, and gender. Much of her work is with midlife and older adults. Dr. England's original research in these areas is published in numerous biomedical and psychological journals, and she presents her work worldwide. In addition, she is also a dedicated instructor and mentor. She has taught multiple graduate and undergraduate courses, including courses in health psychology, professional development, gender, and health. Dr. Graham-Engeland, you can now take over. Thank you.
Thank you so much to all of you for inviting me to speak today, and thank you, Solomon, for that excellent introduction. I will share my screen here. Okay. Is that working? Awesome. Well, I thought I might start by just stating that my background is in social and health psychology. That's my PhD with some extra training in psychoneuroimmunology. So I wanted to mention I'm not a clinician, and I don't even, for the most part, conduct clinical trials. However, I do think that some of the work that I'm doing and that others in my group and in the Center for Healthy Aging are doing with psychological stress and emotion is really relevant to a lot of clinical work. And increasingly, as you heard, I'm starting to apply this work to understanding risk and resilience for older adults, including with cognitive brain health. So I look forward to telling you some about some of this work and getting your thoughts. So I'll just really briefly summarize my research program. So this is sort of the outline for my talk, right? I'll start with kind of why I focus on what I do. Then I'll review some of the key pathways that I see in how psychological stress and cognitive aging are connected based on the literature. Then I'll do a deeper dive into 3 different studies from my research group, recent findings. And then lastly, I will focus on some future directions that I see for this work and some prospects for intervention. Big picture, as you heard, I study how stress connects with physical health and psychological health. And I focus on a number of outcomes. Again, as you heard, cardiovascular disease, physical pain, and outcomes related to cognitive aging. And then I focus on or examine what I think of as mechanisms underlying those connections, right? So physiological changes, particularly those related to immune function and inflammation, changes in behavior, such as related to getting insufficient sleep, and changes in emotion or affect. And of course, a lot of these processes feed back on each other, right? So if you feel more pain, then you can't sleep as well, you have worse mood, worse memory. That can put strain on your relationship, your social relationships, with all kinds of downstream physiological and cognitive consequences. So I'm often thinking about vicious cycles where perhaps we could intervene in daily life. And I think a lot of you do bring in affect or emotion into your work in some way, but I thought I would just sort of describe how I tend to do that. I study both positive emotion and negative emotion, and I really view them as telling us something important and unique about stress and coping. I'll focus on negative mood for the most part today, which of course is related to depression, but is a much broader construct, a more everyday occurrence, right? And everyone experiences fluctuation in emotion. A negative emotion, a negative mood might be fleeting, or we might think of ourselves as being in a relatively poor mood all day compared to how we usually are. And importantly, when I'm talking about negative emotion, I'm naming things like, or thinking of emotions like sadness and anger and anxiety. And again, I think one of the reasons it's important to think about how emotion relates to stress, how emotion relates to health, is that it's a common response to stressful events. It makes sense that if something stressful happens to us, we would experience some negative mood. And so it sort of encapsulates that psychological appraisal of stress, right? It's if something has happened to us that is perceived to be threatening and important to us, then it is very likely that negative emotion will result. And not all stressors lead to negative emotion that persists over time, but the ones that do matter to us, the ones we ruminate about and care most about, are often associated with negative affect. So really underlying my research focus here are three perspectives. One, as I was just saying, that stress and emotion, stress and mood are linked with health via a variety of mechanisms. And I also believe that we really need to know how this all plays out in daily life, how these processes unfold, and that understanding these mechanisms and individual differences in these connections might really help inform specific potential interventions and prevention strategies. Okay, so far this has all been very broad. I'll turn now to thinking about how this all might relate to cognitive brain health specifically. So actually, along with Marty Slawinski, the director of the Center for Healthy Aging, and Chris England and Dave Almeida in the HDFS department here at Penn State, I recently published a review on the importance of psychological stress and cognitive well-being as we age. And as you very well might know, there's a lot of well-established connections here in the literature between stress and cognitive well-being as we age. Older adults, for example, who report higher ongoing psychological stress consistently show worse cognitive performance, and they're at risk for being diagnosed with cognitive impairment and what seems to be accelerated cognitive decline over time. And these types of connections appear to start early in life. In fact, chronic or intense stress even early in life, or intense trauma early in life is linked with long-term worse cognitive health. And stress in midlife, such as high job strain, has been shown to predict reduced cognitive performance later in life as well. So this really means, right, that attention early in life and preventative strategies and attention in midlife to what's going on with stress is likely really important. I know that many of you focus on social determinants of health, and so you're likely well aware that it's been estimated that 45% of worldwide dementia cases would be prevented or delayed substantially through intervention on just 14 pathways. This was recently highlighted in the Lancet Commission reports. A lot of these are overlapping, like cholesterol and diabetes and hearing loss and social isolation. Many of them also relate to behavior, things that people could do, and potentially things that are modifiable: physical activity or reducing sedentary activity, healthy diet, adequate sleep, and social engagement, which I'll highlight a bit today. And what do all of these have in common that is not represented in this schematic shown on the screen here? In our recent review paper, we argue that they're just about all linked with psychological stress and by proxy affective or emotional processes. So here's a schematic that I developed to try to better illustrate this. If you engage in these so-called healthy lifestyle factors, right, sleep and diet and physical activity and social engagement, presumably this should improve your stress and your mood, and biological factors that then push on your cognitive brain health, right? That's presumably the idea underlying why those behaviors are relevant. But of course, these behaviors are not easy. They can be stressful, difficult to change. And our existing stress exposure and how we cope with stress can influence whether or not we are able to change those behaviors. And in addition, stigma related to mental health and aging probably plays in here too, can present other challenges related to stress. And finally, I'm acknowledging here that our social and environmental circumstances, including from early life and as related to demographics, all relate to our ability to engage in healthy behaviors and also influence our exposures to stress and health in other ways. So these factors are all connected in ways that I don't think are always, they're intuitive connections, but not maybe always fully appreciated or intervened on. I do want to just highlight this idea that maintaining social connections and reducing loneliness is critical for maintaining cognitive health and independence as we age. I know many of you in CGNE do some work in this important space. Our social relationships are, of course, strongly linked with our ability to cope with stress and in turn influence our cognitive health and in really interactive ways. So for example, both being isolated and mental health issues make it harder, make it less likely probably that dementia is diagnosed or harder to deal with recommendations to engage in complex behavior like following a new diet. And if you're isolated, it's also harder to regulate your emotions. You have fewer people to talk with, fewer supports to lean on. Just to highlight briefly how some of these factors can be interactive, here's just a few examples from my own group. Former postdoc Nancy Sin has shown that poor sleep heightens emotional responses to stressors. And in addition, former graduate student Karina Van Bogart, shown on the bottom there, and current postdoc Jian King have focused on loneliness a lot and have shown that loneliness seems to modulate emotional and physiological stress responses as well. And I'll share some work of Jian soon coming up that relates this to cognitive performance. I did promise I would also speak to physiological mechanisms that are often the focus of my work and specifically highlight the role of inflammation. And then I'll get to some specific research findings. So since we're talking about stress, I should briefly elaborate, especially maybe for trainees who are newer to this domain, how we get from stress to biological factors like inflammation. So just experiencing a sudden stressful event, even if it's just something that is in your mind because maybe you're worried about something from the past, can activate the HPA axis, the hypothalamic pituitary adrenal axis, of course, one endpoint of which is cortisol, and the sympathetic nervous system, which results in epinephrine and norepinephrine release. And then for example, you see that the hypothalamus in the brain receives information from the brain, activates cortisol, ACTH, and cytokines, including inflammatory cytokine molecules, which all act on each other. These types of responses to stress are, of course, normal, help the body adapt and react to situations. And there's lots of feedback loops in these systems that help the body get back to a state of balance, including that cortisol should dampen inflammatory responses. But with frequent or severe stress, there's a limit in the body's ability to cope, and some of those feedback loops become less effective. So that's one way that stress might lead to higher inflammation over time. And then importantly, I would argue that our emotional responses to those stressors can contribute to their impact, right? So negative emotion could actually be a stressor in and of itself, depending on social and personal context. And when we worry about past stressors and ruminate about them, those can extend the life of stressful life experiences. So I've tended to focus on inflammation because it can provide a powerful physiological or an indicator of immune function and has clear clinical relevance and provides a real bridge between my interest in psychological stress, physical pain, emotional responses, and health. I often look at inflammatory cytokines that we can detect in circulating blood, as well as C-reactive protein or CRP as a broad marker of systemic inflammation. And both are indicative of illness risk, all that they rise with illness as well. But both of these types of inflammatory markers are responsive to psychological stress. I'm going to go kind of quickly over this material because I think a lot of you know some of this, but I certainly want to highlight that it's this chronic elevation, even if it's low grade, chronic elevation of inflammation that seems to be a critical pathway to disease risk. So short-term changes in inflammation have many adaptive functions, but this long-term elevation is linked with cardiovascular disease, metabolic syndrome, Alzheimer's and related dementias, and many other health issues. And again, sort of highlighting how some of these things are connected. Inflammation is also connected with sleep and helps to explain how poor sleep is linked with pain and mental illness. And increasingly, there's evidence that higher elevations in inflammation are also observed in older adults and others who are lonely or socially isolated. Interestingly, there's a ton of research linking depression and inflammation, but not as much research as you might think linking emotion, as I've described it, these affective processes with inflammation, which is important because depression is sort of a unique clinical construct, right? That doesn't just involve emotion, but lots of other factors, including fatigue and behavior-specific cognitions. So very briefly, there's interesting lab studies showing that either that inflammation can cause negative emotion, but also that manipulated negative emotion can increase inflammatory markers. And there are a number of papers showing an association between recalled positive mood and lower inflammation, showing a picture of former graduate student Dusty Jones, who did an excellent review on this. But in terms of negative mood, there's only one study I'm aware of showing an association between retrospectively recalled negative affect and I think a marker of inflammation, IL-6. But that's about it. And it's possible not many people have looked at this, or that there's null findings out there. And I would argue that it's also possible that this lack of evidence of this connection relates to assessment strategy. With retrospective recalled emotional assessment measures, people are asked, like, how did you tend to feel last month? And I don't know about you, but I would find that astonishingly difficult to answer with any accuracy that reflects my lived experience, because there have been good days and good moments and bad moments, right? So in much of my work and in others' work, we try to capture affective experiences that reflect lived experience in daily life by asking people often to report via their smartphone message, pings on their smartphone to tell us, how are you feeling right now? That is a lot easier for people to report on without so much recall bias. One project I've been involved with, where we're beginning to look at some affect-related dynamics in daily life and how they link with inflammation, is the ESCAPE project. This is a project some of you, I'm sure, have heard of. Marty Slawinski was the PI and founder of the original project, and then there's been several R01s that have supported this work since then. It's a really diverse sample recruited from a particular housing development in the Bronx, New York. And it's a midlife sample, about 25 to 65 years of age are these participants. So I'll give you some snapshot of a few findings that I think are relevant with this study. This is a longitudinal burst design study where we did an intense measurement burst for 2 weeks and then repeated that type of burst over 3 years. So participants came into a lab for training. They were given a study-provided smartphone, and then they did 14 days of ecological momentary assessments where we pinged them on their phones 5 times a day, morning and evening, and then 3 random times during the day, where they provided, among other things, emotion assessments. And then they came back to the lab and provided a blood draw. So for momentary affect, we asked participants to rate their current feelings. How do you feel right now on a number of adjectives that you see here? Things like, how happy do you feel? How frustrated do you feel? And then we aggregated, for this particular study, we aggregated those ratings separately for week 1 and week 2, and then overall. And then we also did have a measure of recalled, like a traditional measure, like from the PANIS, of recalled affect, where people are asked to say how they tended to feel over the past month. So these are we have data on the set of circulating inflammatory markers that you see here, a set of inflammatory cytokines and CRP. And for the primary analyses that I'll share next, we aggregated the inflammatory cytokines into one marker representing inflammatory load. Then we used linear regression to look at how the affect variables predicted the inflammatory markers after controlling for a number of things, age, body mass index, gender, education, as well as the number of health conditions participants had. This is a general sample, not recruited on the basis of a particular health issue, and their use of medications, certain medications like statins. So a key hypothesis that I'll focus on here was that measures of momentary negative mood would be more strongly linked with inflammation than standard recall-based measures. And then we also explored whether the momentary affect measures from the week closer in time to the blood draw would link more strongly with inflammation than momentary affect the week before. And in fact, in line with expectations, we found that negative mood from the week closer to the blood draw was associated with higher levels of that aggregated cytokine measure and most cytokines individually, but not CRP. Interestingly, momentary positive mood was associated with lower inflammation in the men only in this particular study. But also consistent with some of that literature I reviewed, no inflammatory markers were associated with any of those retrospectively recalled mood measures or affect measures that we had, positive or negative affect, perceived stress, or even chronic stress in this study. And I thought I'd share with you, we also looked at physical pain a bit. I thought that might be of interest because that pain, of course, is such a key driver of healthcare use, of suffering, of lack of independence with daily life activities among older adults, which is part of why I've looked at it as a health-related outcome sometimes. So in this exact same sample, in the ESCAPE study, we looked to see if there was an interaction between higher negative mood, and I know I'm using mood and affect and emotion interchangeably. We might talk about nuances, but just want to point that out. So higher negative affect and physical pain in predicting these circulating inflammatory markers. I should just note that we also were looking at or thinking about how pain intensity and interference with daily life activities from pain can be perceived of as stressors, right? So we sort of drew on that and stress and health theory to hypothesize that those who reported more pain and higher recent negative affect would have the highest levels of inflammatory markers. Analyses were run using continuous data with the same covariates as I mentioned previously. And whereas before there was a main effect of negative affect on inflammatory cytokines, here there were interactions in predicting C-reactive protein, CRP. Specifically, there was a positive association between pain intensity and higher CRP levels for participants who reported higher levels of recent negative affect, and a similar interaction between pain interference and negative affect. And importantly, as before, there were no interactions associated with, in our exploratory analyses, looking at whether recalled negative mood or affect or perceived stress even interacted with pain in predicting these inflammatory markers. We only observed these interactions with emotion assessed in daily life. So what does all that mean so far? First, I think this is consistent with this concept that negative motion may function as a signal of stress exposure that promotes a positive feedback loop involving higher inflammation, which in turn maybe can promote more negative affect and pain. It's also possible that negative emotion, negative mood may prime the body for inflammatory activity, which in turn may promote pain sensitivity or pain-related disability. This research also supports the notion, I would say, that momentary affect ratings capture something different than retrospectively recalled ratings of mood or stress. So that, momentary or in daily life capture of affect may better represent lived experience and maybe will better link with health outcomes. By the way, I don't have time to really expand on this, but we've also done some related work in this area with an older adult sample from the Einstein Aging Study, which is an ongoing study of older adults aged 70 and older. Actually, we're changing that now to be 60 and older. So specifically, another research focus of mine is just looking at this connection between affect and pain. And we have some preliminary evidence, just briefly, that the association between negative affect and pain intensity is dampened in moments when people have experienced social interactions recently. And it doesn't even need to be a particularly positive rating of social interaction. Any social interaction seems to sort of break apart that affect and pain intensity connection in daily life, even into a future moment about 3 to 4 hours later. So it really backs up the idea that interactions with healthcare providers and others, even strangers, can maybe buffer the effects of stress and negative emotion on physical pain. And again, I know I wanted to mention that because I know some of you, including Dr. Bolds, I think, have worked looking at that importance of staff to resident interaction with, in the context of dementia care, and that others in the CGNE group have run psychosocial interventions, such as looking at emotional expression, like Dr. Van Heetsma, I believe. So a lot of you doing some really cool, relevant work that I think ties into this. Okay, so now I want to switch gears and talk about cognitive performance directly. And this work that I'll mention briefly here was led by current postdoc Jian Kang, leveraging the exact same escape study data set. And these particular findings also leverage Marty Slowinski's really innovative cognitive performance tests that are also done on smartphones in daily life. So it's, as opposed to an in-lab cognitive test, people going about their day, pinged on their phones and asked to not just report on affect, but also to do some cognitive brain games, as we call them, on the phones that capture their cognitive performance. So again, these are diverse adults aged 25 to 65. They were given a loneliness scale in each of these 3 waves of the study. And Dr. Kang classified some participants as chronically lonely if they had loneliness scores in the highest quintile of reporting for this study. The loneliness scale, I should say, was not on the, we did ask them in the later study, we've asked about loneliness in moments, but this was loneliness at a baseline time point with a 6-item scale. So we sort of classified again people who were chronically lonely if they scored in the highest quintile of that assessment. She hypothesized that lonelier people would show the most decline in cognitive performance over the course of the study. And she didn't exactly find that, but what she found is really interesting, I think, and relates to retest practice effects. So, as you might expect, cognitive performance actually improved across waves. Again, this is a midlife sample, although it includes younger into early older adulthood. And cognitive performance tends to get better as you take these tests over and over, right? So people tend to improve, which is what we saw. But second, we saw that chronic loneliness was not associated with baseline levels of cognitive performance on any of these 3 tests I'm showing you here. I should point out, so we had a test that captured working memory, a test that captured processing speed effectively, and a test that got out spatial working memory, and then or global cognition, which is really just the aggregate of all 3 of those. But chronic loneliness was negatively associated with the rate of change in global cognition and the test of working memory specifically, which was a flip back test, if any of you are interested in that. So here this breaks that down. Here's the global cognition plot. This figure is representing changes in global cognition across the 3 years. So it shows that those who were defined as not chronically lonely, the red line, showed significant increases in global cognition, as one would expect, but those who had been classified as chronically lonely did not significantly change. And here's the with the plot with just working memory, which is really similar, right? So the chronic loneliness group did not show performance improvement. In other words, individuals who were not chronically lonely demonstrate improvements in cognitive performance with repeated testing, but those who were chronically lonely in this study did not show those retest effects. And, importantly, there's evidence that a lack of retest effects in cases like this can be a potential marker of early stage Alzheimer's disease. In fact, the pattern we observed is comparable to individuals with preclinical Alzheimer's disease, where previous research has shown that individuals in preclinical stages, represented with a red line here, also don't exhibit retest effects. So we interpret these findings as indicating that chronic loneliness can predict pre-symptomatic changes in cognitive function among young and middle-aged adults. And I won't have time to review it all today, but our group has also linked loneliness and social interactions with cognitive brain health in the Einstein Aging Study, that ongoing study of older adults. And these two papers were with the sample that is 70 and older. For example, Gian recently had published a paper showing short-term associations in daily life with momentary feelings of loneliness and cognitive performance. And former graduate student, and she's now a postdoc, Karina Van Bogert, has shown that momentary feelings of loneliness and intrusive thoughts, sort of ruminative thoughts about loneliness, were linked with mild cognitive impairment, the loneliness and rumination, intrusive thoughts were linked, but only in those who were not married and who had mild cognitive impairment, suggesting that being unmarried, unpartnered could be a risk factor for experiencing loneliness and subsequent intrusive thoughts among older adults. All right, so the last study I'll present some brief findings on. Even more briefly, this is a project led by postdoc Dr. Julie Kircher, currently here at Penn State, where we're trying to bring affect and inflammation and cognitive function together. These are very preliminary findings that we'll follow up on. And some of this work has been conducted with a different data set, the midlife in the United States data set. And Dr. Kircher used participants who completed time point 2 and time point about time point 1 and time point 2. These are about 10 years apart, right? So technically it's MIDAS 2 and 3 waves if you're familiar with MIDAS. She conducted analyses on these two time points with only the participants who did both, which is about 500. I'll show you in a second. Here we go. Yeah, 575 participants. So you can see this sample is a majority white, a little bit more than half women, and the age was about 52 at time point 1 and about 61 and a half, so almost 10 years later at time point 2. So she conducted hierarchical linear regression models across both time points and adjusted for sociodemographic factors, and controlled for the number of weeks in between the cognitive assessment and the biomarker assessment, because this is something that varies a lot in MIDAS, where it doesn't really vary much in that ESCAPE data set or Einstein Aging data sets that I mentioned before. And at time point 1, she found that 2 out of the inflammatory markers were significantly related to executive function measures in this data set in the expected directions. So for example, greater levels of the inflammatory cytokine IL-8 were related to slower processing speed, and then higher levels of the adhesion molecule ICAM1 were related to poorer attention. She did look at negative affect. Negative affect was not related to these executive function measures in MIDAS at this time point. And we also predicted that there might be interactions with negative affect and did not, and inflammation and predicting these executive function measures, and didn't see that here. And at time point 2, you see a lot more associations. So now folks are, again, about 10 years older, and now we see multiple inflammatory markers, again, in the expected direction, linking with, let's see, slower processing speed and worse inductive reasoning. And here, higher negative affect was also associated with worse inductive reasoning, but no interactions again. So I think, again, these are very preliminary findings. This highlights this inflammation cognition link that others have also observed. And I'll be working with Dr. Kircher to weave in momentary affect to better shed light on the impact of psychological stress in daily life. Okay, so in the last segment of my talk here, I just now want to bring this back together into these more integrative theoretical models I've presented and end with some recommendations for research, as well as some policy recommendations that I think findings like I've presented may speak to. So first, in terms of research, I do feel strongly that bringing in ratings of momentary affect or daily affect may really help strengthen research to understand how stress relates to health. And if at all possible, to use EMA-derived or daily measures to really get at that lived experience that I think will particularly matter for our health. And maybe particularly if you're predicting things that also change over time quickly, like inflammation measures or physical pain. A real bonus is that when you have multiple measures in the same people over time of something like affect or pain, you can then, it opens up the ability to ask other important research questions, including how variability might relate to our health, which is something that some folks in my group have been doing more and more with. So in terms of potential interventions and prevention, I think it's pretty clear we cannot usually avoid stressful events, but importantly, emotion regulation is a theoretically viable target for intervention. So there are a lot of individual strategies that could be done, could be taken on, that could involve emotion regulation or, emotion expression, or strategies to get people to engage more with existing social support networks, just as an example. But it wouldn't have to just be strategies at the individual level. It could also be things that at the dyadic level or family or community, society levels that also might really be helpful to improve social and behavioral functioning. So bringing that back into cognitive brain health model specifically, and these lifestyle recommendations that we hear all about all the time. Obviously, individuals should try to follow these healthy lifestyle factors, diet, sleep, physical activity, etc. But I think it's clear they also need to be encouraged by everyone they encounter to prioritize their mental health and well-being. That might include talking about their worries, asking for social support from friends and family, going outside regularly. And we can't forget about the social isolation piece. Some of Dr. King's work and other research actually suggests that even just adding one social interaction a day, even by phone for older adults, can be helpful. Even interactions with strangers can have meaningful benefit. Importantly, though, and we certainly pointed this out in our review paper, the burden for prevention of Alzheimer's and related dementia should not fall solely on individuals and their families. Not everyone, of course, has the resources to put time and money toward programs to support themselves in these lifestyle goals. And worse yet, those who are already disadvantaged tend to face the most challenging stressors as well. So we clearly need policies that focus on early detection, that include ways to help people reduce stress and improve their coping with stress. These types of any prevention intervention efforts should also acknowledge that stigma is often put on older adults and those with mental illness. And I know some of the work, again, from the CGNE group, including that of Dr. Hill, has really been helpful for me to help understand how involving family and friends all the more in care decisions would be helpful in this regard, as would be normalizing the use of hearing aids and among older adults for their families. Clearly, this type of thing is not well incentivized currently, as Marty's really pointed out. One suggestion we made in our paper was to advocate for tax incentives or subsidies for private companies or health insurance providers to encourage them to invest in wellness and stress reduction programs as well. So, I mean, and also community level efforts would undoubtedly be helpful, given research suggesting that neighborhoods with greater walkability and security and green spaces support cognitive brain health, as do multi-generational activities and lifelong learning opportunities. I'm also very sure I don't need to tell this group that more support for caregiving is needed. Again, I know multiple of you folks in CGNE are doing great work in that space. So, you know, more support for caregiving as well as for caregivers, right? And then lastly, I think it's very important at this time in history that we take the time and effort to really, for everyone, ourselves, our families, our employers, for policymakers to get the word out about the importance of our work and you know, the importance of science, the importance of facts, the importance of education and prevention, and for all of those potential players in this to hear that message. And I think I do think it's critical that if we all recognize the role of stress and affect in some of these connections, that and introduce efforts focused on stress and affect into policy, that really could help delay disease onset and reduce healthcare costs and hopefully improve the quality of lives for millions of people. So I'm going to end soon, and I want to acknowledge my collaborators associated with the ESCAPE project, in particular because I highlighted that project so much. That includes Marty Slowinski, the founding PI of that study, and also Graham-Engeland, who was a multiple PI with me on an additional grant that funded it, and many others, too many to name, and the National Institute on Aging that's funded most of this research. And then lastly, my entire lab group, particularly the current postdocs, Jian Kang and Julie Kircher, whose work I highlighted today, and former graduate students, Karina Van Bogart and Dusty Jones. So I will end there, and I think enough time to be able to answer any questions that you have.
That's wonderful. Well, thank you so much, Dr. Graham-Engeland, for this incredible, very interesting, fascinating presentation. There's a lot of positive comments in the chat. I'll read one from Solomon. Interesting findings that I relate with personally as an international student with a sudden change in communication and time differences with family. Thanks, Dr. Graham-Engeland, for bringing this topic to our attention to be conscious of the power of social network. Do you want to comment on that at all?
Well, thank you. My pleasure. And yeah, I mean these social connections, right? Again, so many of you do work in this space. It's intuitive, and yet to be able to see the science bearing out, you know, the impact that this has in our lives in all these interconnected ways, right? And it's behavior, it's our psychology, it's our physiology, all coming together. And it's one of the most powerful things that we can do to improve our health and well-being, is to engage and be connected, however it is we can do that. And interestingly, some of the work suggests too that it's, you know, obviously in-person stuff is great. And we were chatting ahead of this session about how, you know, when we can all get together to have presentations, that networking in person is wonderful, but online stuff is good too. And, you know, and this is a great example of that, but also just a phone call, a text, right? Those types of ways of keeping us connected are really meaningful too.
Yeah, I have the pleasure of working on the Teaching Nursing Home project, and our students are interviewing older adults in a care community, and they're asking them what matters to them as part of this assignment, and 90% or more of the time, the older adult is saying, my family. And so then we kind of talk about, you know, do they have opportunities to connect with their family? Do they have a phone? You know, and then talking about how we need to make sure we find opportunities, create opportunities for them if they're not readily available for them. And your research certainly, shows us strong evidence why that's so critically important. As you said, it's intuitive, it makes sense, but this really validates that. So thank you so much. Lots of positive comments in the chat. Fascinating presentation. Thank you. Excellent. Wonderful. There is a question that popped up actually in a different part of the online piece here. It says, thank you for this wonderful presentation, Dr. England. I have a question. Is the emotional pain that leads to increased inflammation, does it occur in brain cells? If yes, does this relate to Alzheimer's and dementia?
What an interesting question. One thing that question reminds me of is some work by the neuroscientist Naomi Eisenberger and other colleagues that she's trained. She looked at how brain activation to social pain, being excluded, for example, experimentally, triggers very similar areas in the brain that are related to physical pain. So there's some interesting brain pathways, I think, that help explain how, we only have so many systems in our body that respond to psychological stress, right? We don't have a whole separate system in our body that deals with that. And then we have, and a separate system that deals with physical pain, a separate system that deals with, maybe more urgent physical stressors. So, we have this amazing ability to be responsive to psychological stress, and that's good for us. It helps give us motivation, perhaps, to seek social engagement sometimes, but it also means that these physiological stress systems are getting activated all the time. So I don't know if that's really getting at the question, but I think it's relevant. I don't think there is a particular one-to-one translation of, one area in our brain or a particular type of cell. But in terms of going back to the inflammation piece, most of that work I presented was just on circulating inflammation, not central nervous system inflammation, but there are connections there. And maybe that's what this question is getting at, right? So how do we get from, broad overall, okay, you have chronic low-grade inflammation to Alzheimer's disease? It's a very complicated puzzle. I think, as you've probably heard from other presenters, inflammation is probably a piece of that. There are ways that inflammation in periphery gets signaled to the central nervous system. You could start to see inflammation as in the central nervous system being a mechanism, but one of many. So glial cells in the brain can produce inflammation as just one example. But I think then there's a lot of other physiological pathways as well. Lipid metabolomics seems to be a key hot thing these days. And again, we have some early studies looking at stress and some of those pathways as well. And it's going to take, to get at this, right, it's going to take really integrative work that I think acknowledges that humans are not, this physiology is so complicated. There's a whole new project that I'm starting to get underway. It's just at the proposal stage. And I'm just a piece in a very large group working on this, but we're acknowledging, like, there's so many in mouse models and other animal research, there's cool findings where it looks like you could start to reverse the signs of Alzheimer's disease, right? And then we get drugs that we bring to the market, we, not meaning me personally, we get brought to the market and they don't work. And people throw out why is that, right? Well, there's so many of think of all this stress and behavior and all of that is so uncontrolled and so related to how.
Yes. So not only so complex, but so individualized too, for different people. So Tracy says, great presentation. Thank you. Can't help thinking how much more exacerbated these results could be for visual, persons experiencing visual and hearing impairments. You did mention hearing impairment at one point. Can you comment a little bit more about that?
Yeah, it's a great point. That Lancet Commission work highlighted hearing loss as one of the biggest things. Like if people would have more support using hearing aids when they're needed and engage more with that would help. And there's probably multiple pathways underlying that, but one, of course, is social engagement, right? So if you have an older adult or anyone who's not able to hear well, they tend to not have as much conversation. They're sitting in a room where talking is happening around them and maybe disengaged. It's harder for them to communicate their needs. And that's probably one of multiple ways in which there's a really strong connection there. So I think she's right. It just gets exacerbated.
Yeah.
Yeah.
So Dr. Diane or Diane Bartum, excuse me, says, wonderful presentation. I thought it was so interesting to include 25-year-olds in your studies.
Mhm.
I think this helps communicate the impact of stress, loneliness, and other stressors, how it impacts mental health, and might even help young people evaluate their situations and seek help. I was also struck by the evidence of the impact of stress across the lifespan, essentially.
Yeah, that we see
Implementation.
those connections, right,
Yeah.
in this
Yeah.
huge age range. We have done some preliminary work looking at like a stress inflammation connection getting stronger in that study as people get older, which makes sense. But I think it all the more sets up that argument that, if we could just be starting much earlier with prevention. I mean, all of this stuff, we make this argument in that review paper, just all of these behavioral strategies accumulate and stressors accumulate as we get older. And it's not like you have one bad day and suddenly you're at risk for disease. It's the accumulation of days and years. So yeah, really.
Yeah, and I really appreciated your policy recommendations. Have you thought about educational, and obviously some of those policy recommendations could be
Yeah.
integrated into education, but from an educational perspective, how could this be addressed?
It's so important. It's not really my area, and we wound up being short on space on that paper and had to cut. I wrote paragraphs and paragraphs on that and then cut it out. But I totally think, right, like we should be teaching about aging and in elementary school. We should be teaching about the importance of multi-generational contact and encouraging it from an early age, helping people understand how all this stress and coping stuff is relevant to their own trajectories. Everyone is going to get older and, needs to sort of be thinking that through earlier. And I think that's a big piece of it. That would be wonderful. I'm actually right now with Marty working on like a piece that's sort of related to that review paper that we're hoping to get out in like a popular press sort of story. And I'll try to fit that in, right? Like we're just to try to get that word out more because no one reads our research articles.
I think that would be really valuable. I think, the other thing that, as you were talking about, the attention to and the prevention of stress really, needing to be done across the lifespan, essentially. You mentioned trauma and, I think there in healthcare, there is some work being done certainly on trauma-informed care and the importance of recognizing that people do experience different types of trauma. We may not be fully aware of what that is, but that it certainly has an impact on them, whether they're the patients we're serving or whether they're the care partners they're delivering the care. So, and you mentioned caregivers, informal caregivers of people in their homes and the stress of that as well.
Absolutely.
Yeah.
I think you've done some work with that, right? And others, right? If helping the caregivers would help everybody. Absolutely.
Absolutely.
And I think you mentioned like this idea of individualized treatment care, right? So if we have, recognizing that some people have had traumatic experiences as young kids or in early adulthood or what, the weight that all the differences that brings and the need to be more targeted with our prevention and intervention care. Yeah.
Well, thank you so much for sharing all this amazing research, and the importance of your work is, just incredible. Just certainly looking forward to where you take it next, because I think there's so much more we can learn, and has so much value to our individual and collective lives. So thank you so much for sharing all of this with us.
My pleasure.
We will be wrapping up in a moment. So just a quick reminder to everyone, as participants, when we close the webinar, the link to the evaluation will pop up in your browser, but it will also be emailed to you within 24 hours. So we encourage everyone to complete the evaluation on the session. And again, Dr. Graham-Engeland, thank you so much for sharing your expertise with us today.
Thanks for including me. Great.